We'd sure like to get started. I want to welcome you all. I'm Craig Blumenschein, the Senior Public Affairs Producer from Wyoming PBS, and I am very pleased to moderate this very important discussion on Medicaid expansion this afternoon. I want to thank you all for attending. We have a packed house nearly, and that's good because this is an important issue for Wyoming. It's worth noting that although the Wyoming Liberty Group is sponsoring the event today and does oppose Medicaid expansion in Wyoming, Wyoming PBS does not state opinions on public policy. Rather, we work hard to give all sides of issues an important voice, and that's my role here today, and that's why I've agreed to serve as moderator. Wyoming PBS will be live streaming today's discussion, so we're very proud of being able to do that. And I want to let you know that the Wyoming Liberty Group has asked me to moderate a balanced discussion. Very important to us. And before we do begin, I would like to recognize some folks. Susan Gore and the staff of the Wyoming Liberty Group. I want to thank you for organizing today's event. Susan is with us today. Thank you, Susan. I also saw earlier that State Treasurer Kurt Meyer is here with us today. Mr. Treasurer, if you could rise, thank you very much for coming. And there are several, too many to name, members of the Wyoming legislature with us today, but for those of you that are here, I would sure like you to stand and be recognized today. Thank you very much for attending. Also at everyone's table is a report that was released in December of 2019 and authored by the Wyoming Department of Health. It's titled Medicaid Expansion in Wyoming, Enrollment and Cost Projections. One of the report's lead authors and contributors is Franz Fuchs. I hope, Franz, I pronounced your name correctly. And he's the Policy Legislative Liaison for the Department of Health. He is with us. Franz, if you would like to stand. Thank you. And I want you to know, and others to know, for those of you that are viewing with us online today, we have that report available at wyomingpbs.org/Medicaid. So if you want to take a look at the information that I think is certainly very, very data that's very important to the discussion that's available to you. Finally, I want to introduce to you Jen Davis, the Health and Human Services Policy Advisor to Governor Mark Gordon. Jen's with us today, and she would like to say a few words. Jen?
Good afternoon, everyone. I'm Jen Davis. I'm new to the governor's office. I am the Senior Policy Advisor for Human Services. So Medicaid expansion is definitely on my plate that we're looking at. And I just want to say thank you for allowing us to be here today for this discussion. We are really anxious to hear this discussion and hear both sides of the issue. So I appreciate the opportunity to be here and meet many of you today. So thanks again for having me.
You know, in preparing for today's discussion, I turned to Dilbert, the comic strip that appeared in Saturday's Wyoming Tribune-Eagle. I think it's relevant. Ashok, the young and able intern, walks in and says, well, this data can only mean one thing. And Dilbert, of course, who is the frustrated engineer who tries to find logic and righteousness in this evil and crazy business world, replies, actually, it can mean about 17 things. And I think that's where we might be with the discussion here today. There are lots of issues, there are lots of sides, and we're going to get a chance to dive into all of that. Just briefly, let me give you a little bit of background. On July 30th, 1965, President Lyndon B. Johnson signed into law legislation that established Medicare and Medicaid programs. Beginning in 2014, the Affordable Care Act gave states the authority to expand Medicaid eligibility to individuals under the age of 65 in families with incomes below 133% of the federal poverty level, and standardize the rules for determining eligibility and providing benefits through Medicaid, CHIP, and the health insurance marketplace. To date, 37 states, including the District of Columbia, have adopted Medicaid expansion in one form or another. Medicaid, together with CHIP, provides coverage to about 1 in 5 Americans, or about 72 million people as of July of 2019. And as of December of 2019, there were 54,194 Wyomingites enrolled in the state's Medicaid program and 3,191 in Wyoming's CHIP program, for a total program count of 57,386. I want to introduce now our panelists who have graciously agreed to present their views today. My introduction will be very brief, and you will find bios in more detail at your desk or at your table, and I encourage you to read those. On my far right is Jan Cartwright. Jan currently serves as the Executive Director of the Wyoming Primary Care Association. Next to Jan is Senator Bo Beitman. He represents Senator District 21. Senator Beitman currently serves on the Senate Minerals Business and Economic Development Committee and is also on the Senate Revenue Committee. Dr. Jan MANSELL, is president of the Wyoming Society of Anesthesiologists and is the Campbell County trustee for the Wyoming Medical Society. Next to Dr. MANSELL is Representative Sue Wilson, who represents House District 7 and is the chairman of the House Labor and Health and Social Services Committee. John Haynes currently serves as the vice president of the Wyoming Hospital Association. To his left is NAOMI LOPEZ, and she serves as the director of healthcare policy for the Goldwater Institute, a conservative and libertarian policy think tank located in Phoenix, Arizona. And to my immediate right is Representative Dan ZWONITZER. He represents House District 43 and is the chairman of the House Revenue Committee. So to our panelists, thank you all for attending today. As we begin, I want to give you, our audience, and for those who are viewing on live stream, every opportunity to participate. You can email me your questions. I'll see them in real time to medicaid@wyomingpbs.org. If there's something on policy or something on policy questions that you feel we're not covering, please do so earlier rather than later in the discussion, and we will have a chance to see them. Again, that address is medicaid@wyomingpbs.org, and we encourage those who are viewing via live stream to take advantage of that as well. So here we are. State lawmakers on the Joint Revenue Committee, Interim Committee, voted 8-5 to move forward with a bill authorizing Governor Mark Gordon to expand Medicaid coverage in Wyoming. Later last year, should Wyoming expand coverage, the best estimates predict there will be approximately 19,000 new Medicaid enrollees by the end of the first biennium, supported by an initial biennial appropriation of $18 million in state funds and $135 million in federal funds, as the federal government will reimburse expansion now at the rate of 90% beginning in 2020. We've developed a bank of questions that we'll explore that what Medicaid expansion might mean to Wyoming. But as we begin, I want to give each panelist the opportunity to expand on the following statement. I support or I do not support Medicaid expansion in Wyoming now because. And we'll start at my far right, Ms. Cartwright. And panelists, please turn your microphones on before you speak, and you can leave them off while you're not speaking if you choose.
Good afternoon. Thank you, Craig, for the introduction, and I want to thank our host, Wyoming Liberty Group, for providing this discussion opportunity. I also want to thank Wyoming PBS for facilitating this discussion. The Wyoming Primary Care Association and its members support Medicaid expansion because community health centers in the state are the ones that provide primary care to people who fall into the Medicaid gap. And we will have a diagram that talks about who that gap population is at the registration table. Health centers also provide integrated care, including behavioral health, dental, and reduced pharmacy benefits. Medicaid is an insurance plan for people whose employers don't provide health insurance or for people who do not qualify for subsidies in the individual marketplace. I think it's important to look at some of the comparisons that will be made today because we are not always able to compare apples to apples, and Wyoming's population is unique. I am looking forward to talking more about this during the discussion. It's also important to note that no state has taken away expanded Medicaid coverage to the new gap population. Of course, there have been changes to state plans, but no full-scale withdrawal from the federal program because states have seen then that people have better health care outcomes, they have improved access to care, the affordability of care is positive, state budgets see savings, state revenues see gains, overall economic growth, healthier workforce, reduction in poverty, healthier moms and babies, and the list goes on.
Thank you very much. Senator Beitman.
Thank you, Craig, and thank you, Wyoming Liberty Group, for inviting me here. At first, I was a little nervous about possibly coming down and talking and wondering how this was going to shape out, because typically Medicaid expansion discussions devolve quickly to a us versus them, good versus evil type of argument. And before I get into why I oppose Medicaid expansion, I'd like to bring us back to what we all probably agree on up here, and that is we all want affordable health care. We want lower costs. We want access to good quality insurance, and that we all have health care coverage. It's the debate up here and in the legislature is going to be how we go about getting there. I support the free market approach. I do not support expanding Medicaid. I think it's just doubling down on more government. Government has created this problem of Medicaid and higher healthcare costs. I think doubling down on expansion will only make things worse. I think it's time to stop and try a different direction. And I'm excited to talk about my ideas and hear more about the people on the opposing side and what they have to say. Thanks, Craig.
Thank you, Senator. Doctor?
Hi, I'm John MANSELL. Several people in this room would rather I not be talking today. I'm one of them. I would rather be in the clinic with my patients today. That's where I should be. But as a citizen of Wyoming, as any of us would, if you see someone about to step in front of a car, you involuntarily grab them and keep them from getting run over. And my concern as a citizen who wants to see better health care access, and for the state of Wyoming to succeed, I feel like I need to grab the arm of the legislature and say, you're about to step in front of a car. Everyone on this dais, I think, agrees that we have a problem with health care access and cost right now. Everyone up here, I think, is a very good person. I don't think anyone up here has any bad will in them. Having said that, we obviously have very different ideas about how to solve the problem. And because I'm on the front lines of health care literally 6 days a week, I think I might be able to contribute something today to show you that there are other ways and that Medicaid expansion is probably not one of them, at least not successfully. And the other worry that a lot of the doctors in my community have is if we expand Medicaid, we're going to break the core Medicaid for those people who currently use it and desperately need it. And for that reason, I'm here today. Thanks.
Thank you. Representative Wilson?
Thank you. And first, thanks to Little America. Seeing as I live in Cheyenne, I often joke that when I develop Alzheimer's and start wandering away from my facility, people should just look for me here because I will assume that this is where I belong. So I guess it's starting. Here I am. I asked the preparers of this to put me in the middle because that's about where I am on this issue. Back in 2015, I actually sponsored an expansion bill with a sunset date. And so as some people have said up here, I mean, I certainly agree that to have health insurance would be a very great benefit to people with low income who haven't got access to insurance now. I mean, that is, I think, very obvious. But I won't vote for it unless I can see a clear new revenue stream because $20 million is $20 million that right now we don't have. I mean, we've tried, even on the Labor Committee, we're trying to rebase nursing home rates and various other things for the people and the services that we have now, and we don't have money for them. So I'm not sure where to get money for something new. So I would be glad to hear that, but until then, I won't vote for it. But we'll continue trying to solve the problem.
Josh? Thank you.
Hello, thank you, everybody. My name's Josh Hannes. I'm with the Wyoming Hospital Association, and thank you to everybody that put this event on and the other speakers on the panel. I appreciate the opportunity. So the Hospital Association has been a longtime supporter of Medicaid expansion in Wyoming, and maybe even more so today as we've been able to review the demonstrated evidence of the benefits that expansion has brought to other states. I'm certainly glad to hear and knew beforehand that the other speakers on this panel are supportive of access and low cost and preventative care and all those things. And I guess what I could say is that because we've had the experience of watching other states expand Medicaid and implement their programs, we're able to see that those goals are achieved by expanding coverage to those folks. People are accessing preventative care. They're getting access to medications. They're getting access to mental health treatment. But for hospitals, particularly our rural hospitals, which is a majority of them here in Wyoming, is that they operate on very slim or negative margins. And they are community hospitals, and they exist to serve the community regardless of their ability to pay. And they do that, and we have a physician here who does that. In the hospital setting, on an annual basis, there's north of $100 million of care that's provided that's not compensated for, that's provided for free because people don't have coverage. Oftentimes they find themselves in an inappropriate setting of care because they can't access the appropriate care that they need. And what you see with care that revenue that we're short is that we're not investing in new capabilities, we're not investing in aging facilities, we're not investing in recruiting more physicians and providers to serve our communities. And what you see as a result of that is deteriorating services, and in some cases eliminating services. The inpatient behavioral health situation in Wyoming right now is such that you're losing that capacity, and it's creating a financial strain on the state. I would echo Jan's comments. Additionally, that 37 states have accepted. Nobody's turned it back once they've had it. There is evidence of the benefits that it brings. And there's an opportunity that if we accept expansion, it's either not working for us or there's a different, better solution, we can go back. And so I'm excited to continue the conversation, and thank you once again.
Josh, thank you. Naomi.
My name is Naomi Lopez, and
Excuse me, Naomi. There you go.
my name is Naomi Lopez. And I'm the Director of Healthcare Policy for the Goldwater Institute based in Phoenix, Arizona. I actually work remotely from my home in Springfield, Illinois. I am here today to talk about the experience of Medicaid expansion in different states. I'm a health policy expert. I've done original research on expansion using data sets from American Hospital Association and the Medicaid HCUP databases. So I can talk in very fine detail about what happens after expansion in states. But I'm also here to talk about what you don't see when you talk about Medicaid expansion. Enrollments have surged well beyond estimates in most states. In fact, in some states, you're looking at doubling or tripling the anticipated enrollments, largely because people will drop their private health insurance and enroll in Medicaid. You've also got higher costs than anticipated. Take a look at New York State right now. They're facing a budget shortfall of billions of dollars because of the Medicaid program. And the cruel irony of the Affordable Care Act is that the expansion population is reimbursed at $9 for every dollar that the state spends. The original Medicaid population, the most vulnerable among us, it's about $1 for dollar. So what happens when New York has a budget shortfall or when your state has a budget shortfall? Lawmakers will be tempted to cut services to the most vulnerable, the people that need that care the most. That is probably the biggest reason why I oppose expansion. But you've also got problems with access. You cannot just hand out Medicaid cards and expect that people will actually get the services. When you take a look at the number of physicians that aren't accepting new Medicaid patients, you're actually creating yet another problem without addressing the fundamental root underlying causes of the supply side of healthcare providers. You've also got a situation where people like to trumpet that this is a solution to rural hospitals when it's actually not. And I can go into much greater detail on this. But the bottom line is that the model of rural hospitals must change. It's an outdated model, and unfortunately, it's not going to be without some growing pains. But there are some successful stories out there of rural hospitals that have been able to retool and better serve the needs of the populations that they have now, particularly for the year 2020 and going forward. And then finally, we absolutely all agree that access and affordability are what we're actually going for. There's no shortage of money going towards the problems of low income and lack of health insurance. It is a question, though, of a lot of bureaucratic rules and regulations that really prevent thoughtful, creative blending and braiding of these funds to actually meet the needs of those individuals in the ways that better meet their preferences and actually focus on patient care.
Thank you. Chairman ZWONITZER.
Thank you, Craig. Again, Dan ZWONITZER, District 43, and Chairman of the Revenue Committee that brought the bill forward this year as a committee bill. As I think you all know, we've been talking about this issue for 7 or 8 years, and I certainly think it was a great deal when I was one of the few people who brought it back in 2014 when we had 95% match. I thought that was a great deal for Wyoming. It's not as great a deal now, but when I look at the issue, I say the pros still outweigh the cons. And basically my thought process is this. I think anybody who works in healthcare knows the system is unsustainable right now. In the next 15 or 20 years, it's going to crash or it's going to do something that's drastically different than how it looks now. We can't keep having 10% insurance raises year after year without some crisis happening, and we're delaying and delaying. Wyoming can offer Medicaid expansion now, like 2/3 of other states, help our residents. All the studies that I've looked at, save a few that I don't think are quite above board, say that costs either stay relatively the same or in some cases go down. And so when I look at our population and the people who can get access to health care today, I think we should do that for them. Is it sustainable? No, right? We have a rural population. You know, we have higher rates of people who use tobacco or vape or drink, a much higher percentage of our population that does not seek medical care right away and saves that till they're at the end of astronomically expensive problems. And so anything we can do to encourage that access to low-income people to get to those hospitals quicker. I don't really want to talk about cost shifting today, but it's my belief that getting them access now will save massive expenses in the future in some of those cases. So I look forward to answering questions.
Thank you very much. And again, I want to encourage our viewers who are not with us in person today to look at the report authored by the Wyoming Department of Health. It talks about using states' other experiences over time, and we have a little bit of a benefit now. And I think that the statistical modeling that the Department of Health did might be refining things to give a better picture of what might happen in Wyoming rather than what happened in other states. All right, as we get into the question part of this now, and again, I encourage you to email your questions to medicaid@wyomingpbs.org. First question is, and this was submitted by a viewer, how will the $130 million that Medicaid expansion brings to Wyoming over the biennium impact the healthcare economy? And again, we don't expect all panelists to answer every question, but we do want to try to hear from both sides for each question. So whoever would like to take a crack at that first. Yes, Jan?
Thank you. One of the things about Medicaid, so let's talk about Medicaid as an insurance program. So Medicaid is an insurance program, and so more people with insurance will lower costs for all residents. We already pay the highest insurance premiums in the country, and once we have more people in the health insurance pool, that's really only going to help not only lower our costs because we're not paying for people who use the hospital as their primary care and increasing hospital costs, but we're also really stabilizing the healthcare system and the other reasons that I listed earlier. So that's where I'd leave it.
Thank you. Yes, Dr. Price.
So let's say that we do put $130 million into the system here. Realize that knowing that Medicaid on average across the country only pays 86 cents on the cost dollar, that means that you can expect that the people who provide care are going to lose the inverse of that. They're going to lose about $20 million because they're going to be providing care for these people, but they're going to be losing 14 cents on the cost dollar for every person they take care of. And I can give an example. I brought this up as a prop, had to borrow it from a local doctor. That's X-ray dye that we use when we do injections or procedures for patients. It makes doing the procedure safer. We know where we're putting the drug in the body. That cost me $9 a milliliter. Medicare pays me 35 cents a milliliter. Medicaid pays me 0 cents. Now, I still take the Medicaid patient into my office, and I still take care of them as I would anyone else. But I lose money every time I take care of them, but I won't turn them away because I think I'm a good human being, and I'm also a patriot. But at some point in time, we're going to go from being able to be good human beings and patriots to not being able to keep the doors open to take care of these very nice people that we want to take care of.
Would anyone else like to expand on that? Josh?
There we go. Dr. Mansell is not wrong. I can't argue with that. Medicaid and Medicare do pay below cost. I think one of the things to keep in mind is that there is a significant portion of our population who's not seeking care at all, or when they do, there's zero reimbursement attached to the care that they provide. In terms of that money flowing into the state, what else does it do? A number of studies in a number of states that have expanded Medicaid, Montana, Louisiana, Colorado, for example, have seen obviously revenues grow within their budgets, but then they've also seen the expansion of jobs in a number of sectors, mostly healthcare, of course, but other professional services, construction. That you're employing more people who are paying taxes in your communities, building homes, spending their dollars in local communities. So that money that comes in for people's care takes care of people, which is the most important part, but also has benefits across your economy in the state and in your local communities.
Naomi?
So I would like to take a more 30,000-foot view on this question. So of course you can spend money on any sector of the economy and it will create jobs, but the issue is, what are you actually doing to increase access and affordability with that money? Let me give you an example. I participate in what's called direct primary care. It's a general practitioner who charges $75 a month for me and $25 a month for each of my children. We have pretty much 24/7 access to our provider. We also get dramatically discounted x-rays, labs, and for prescription drugs, my son is on Montelukast, which is the generic of Singulair. The list price on that is $120 a month. If you get it through GoodRx, it's about $60. Through my employer plan, it's about $16. But getting it through my direct primary care doctor, 10 milligrams for 30 days supply, it's $1. So think about how much it costs to take your child to get their ear checked at urgent care. It's easily $100, $150. That's pretty much what I pay every month to have 24/7 access. I can text a photo of my daughter who cut her foot at the swimming pool and ask if we need stitches. I can text my provider to find out if my son's fever is something that needs to get checked that day. So when we talk about spending money on healthcare, we need to actually think a little bit harder about what is that money delivering in terms of the patient. We need a patient-centric view. For every dollar that you're spending on healthcare, are you actually hiring someone to bill the insurance companies? Are you hiring an administrator? Are you hiring someone to deal with more onerous government regulations? Or are you hiring someone to actually get your kid's ear checked? That's what we need to be focusing on. There's a lot of innovation happening in the healthcare space. I'm most excited about pharmacy scope of practice, where pharmacists would have more prescribing authority and diagnostic authority over treatments. But there are a lot of areas where you can actually improve the delivery of care at a lower cost and really break away from this idea that government spending is going to be some kind of silver bullet to what ails your healthcare system. It is not. What is going to actually fix the healthcare system is focusing on patient-centric solutions. And I think that is not what Medicaid expansion is going to provide.
Thank
if we
you.
do it here.
Thank you, Naomi. Senator Beitman?
Real quick, I think what it does by you is it grows government, and as a limited government guy, that is obviously against what I want to do. What you're doing is expanding a current entitlement program that we're already having a hard time controlling costs. We have an entitlement called K through 12 education with a $200 million deficit, and it's going up every biennium. Medicaid costs are going to start eating into our budget, and before you know it, we're going to have healthcare and education consuming almost the entire state budget of the state of Wyoming. What that means to taxpayers is higher taxes, less services of what the government's actually supposed to be doing, and it's just, I don't think that's what my constituents elected me for. I certainly did not run on expanding Medicaid and expanding government. That's not what they want, and I'm here to represent them. Thank you.
Thank you, Senator. I want to move on. Oftentimes when we talk about Medicaid expansion, we talk about the medical services side of the issue, and I think sometimes the mental health services part of Medicaid expansion, or even in general, gets lost in the discussion. So the question is, when we hear the term Medicaid expansion, what does that mean to mental health services? Will it impact in a positive way or a negative way the mental health services that are available to Wyomingites? Jan.
Thank you. One of the focus areas of the Trump administration has been the opioid crisis. New substance use disorder funding has allowed Wyoming health centers to add new behavioral health staff even in our smallest centers. These professionals are effectively helping people addicted to opioids or other substances. While Wyoming does not specifically have an opioid crisis, the state does have one of the highest suicide rates in the nation, And emergency care for people who are having mental health crises affects every county in our state. And really, the Title X costs are something that the legislature has to deal with every biennium. So I think that behavioral health is definitely a part where we'll see a positive impact. And I want to talk about quickly an Idaho Press article that talked about the community-based substance abuse treatment portion of the Idaho Department of Correction budget shows a big drop in the governor's recommended budget for the next year, almost 30% less in state general funds. That's almost entirely due to Medicaid expansion. Josh Tuwalt, state corrections chief, said that 93% of the parolees and probationers currently receiving services through the division are eligible for newly expanded Medicaid program, so that the state will save $2.8 million, including $1.7 million from the state general fund. And it goes on. I'll stop there.
Mental health services, Chairman Wilson.
Thank you, Craig. This is an area where on the Labor Committee we are trying to spend a little more time working on this because I do think this population, so people between 19 and 64, typically single people, I think access to mental health services would be an enormous help to a lot of people in this area. And even if we do not expand Medicaid, I have spent a little bit of time with the Department of Health and hopefully more time in the next interim. We didn't really get to look into that this interim much. If we were to just do a mental health waiver specific for that population, not the whole expansion population, but for that population for mental health services, the federal government would only pay 50% of that. So the question is expanding just mental health services to a certain population at 50%, you know, how does that match up financially to expanding everything to everybody with us only paying 10%? I mean, I don't mean to dismiss the human side of it, but there's just a math equation in that. And I think that is something that we really need to look at a lot. But I want to throw in one other thing, and that's the reason why I'm sitting in the middle, because my brain is full of nuance on this whole thing. But this relies, or has to do with the last question as well. And workforce is a significant issue here. I mean, you know, we can expand insurance to everybody as much as we want, but if the person hasn't got a provider to see, then their insurance card, whether Medicaid or, you know, Cigna, Blue Cross, whatever, doesn't really do them much good. So whatever we do, the workforce problem is still a major part of the whole discussion.
I just want the panel to know my next question has to do with exactly that, so we'll get to that in more detail. Yes.
Just quickly on the mental health and like Representative Wilson said, this is mental health access and care and treatment has been an issue for years and years. And what I would say is that I'd be careful to separate too much behavioral health issues from physical health issues, as people often have comorbidities, and treating them in tandem and simultaneously, and opening up access to both sides of that kind of treatment are important. And Medicaid expansion for that group up to 138% of poverty, this would create that access on both sides.
Yes.
So I escaped the state of Illinois. My wife's from Wyoming, and we moved here 9 years ago. And one of the interesting things about living on the northern Illinois border between Illinois and Wisconsin is the Wisconsin doctors had made the observation to us in our state medical society that they had about 20 or 30,000 Wisconsin Medicaid recipients who all lived in New York, New Jersey, and Pennsylvania. And the reason is it was a shorter time to hop in the car and drive to Wisconsin and get Medicaid-covered health care than it was to be on the waiting list in those three states, because they didn't have enough workforce to cover it. And one of the things that we have seen in other states that have expanded is that the estimate was X number of people, but actually 2X showed up on average. In California, it was 400% of what was estimated, in part because the census counts someone living as an adult inside their parents' home is getting a third of the income their parents generate, and also because the census counts welfare income as zero, whereas Medicaid counts it, or Medicaid counts as zero, the census counts it as income. So that's part of the reason we underestimate. But the other reason is what we have seen is medical tourism. Even if all the Medicaids in the states were exactly the same, the problem is the healthcare infrastructure gets saturated, overwhelmed, and people are literally moving from other states to here. So in Campbell County, we've had many discussions about our patients from Sacramento, San Diego, the Bronx, Brooklyn, Atlanta, and they moved here to a large part because of the access to health care, but also because they live on a dependency check, and their money goes a lot further. So one of the concerns we have in healthcare is you're not going to get an extra 20,000 people here. You're going to get an extra 60,000 people here. And
Excuse me, Doctor, do you have any specific comments on mental health availability and its access?
Yes.
Thank you.
And that is, a lot of these people have mental health problems that will also stress your system.
Thank you so much. Appreciate that. Thank you. And does anyone else have any comments relative to mental health access? Okay, I'd like to move on. Chairman Wilson talked about workforce, and Chairman ZWONITZER heard a group of University of Wyoming medical students talk about how Medicaid expansion for them would be a big deal in whether or not they wanted to work in Wyoming, lessen burnout, et cetera. So my question is it accurate or not accurate to say that Medicaid expansion would assist in the workforce issues that Chairman Wilson talked about briefly? Chairman ZWONITZER?
I think that's completely accurate. So hopefully you all saw the study that Wyoming lost more population than any other state last year. Like 1% of our population left this state. And we can talk about it was employment or looking for access to services, whatever it was. That number, and it might be biased, but in the 5-year average of what we look like in 2040 in this state, our population goes up 40,000 people to about 600,000. The number of working age adults, 25 to 54, I think is the number, stays the exact same. We're going to gain 40,000 people the next 15 years, and the number of people who are in our workforce is staying the exact same. We have 4 of our 23 counties are projected to lose population in the next 15 years from where they're at now. It's not sustainable. In the next 5 years alone, we're projected to lose 1,000 more jobs. They equate that to about 4,000 people in the state that won't have employment. And what are they going to do? They're probably going to be forced to move to somewhere else. The nice thing about Medicaid expansion in this respect, if they can, they're part of the community, they want to hold on, if they can have access to, some part-time jobs to get them through until they can find another full-time employment in this state, and we can keep them here, that's great. Once they leave, we're not getting them back. And so in that respect, Medicaid expansion, and you've seen this in studies in Montana and Kansas, does fill the gap for some people from leaving the state when they lose their jobs. And I think you all know we are likely to lose some more jobs, especially in high-paying energy sectors.
Do we know how it impacts the recruitment of healthcare professionals?
I'm sure we do, but I'm probably not the right person to ask.
All right.
I can answer that.
Thank you.
As someone who works as a recruiter for both our hospital and also for my specialty, the medical students have gotten much more sophisticated in the last 20 years, and one of the things they do is they look at the payer mix of where they might move, because the payer mix determines what their income's going to be. And when you look at the fact that, unfortunately, Medicare and Medicaid pay less than the cost of care, as that number gets larger, it's harder for me to recruit someone to that job, because they know that they just will never make what they could make in another environment where there are fewer Medicaid and Medicare recipients. And they're making a commercial decision for their career, and I respect that, but it does cause a negative impact on the ability to recruit.
Chairman Wilson?
It's the guidance, flailing with my thoughts in there. I don't actually think Medicaid expansion would be of help to the workforce. There are a lot of national type studies that say, well, if we put more money in the system, that's great because then we can hire more people. The problem in Wyoming is not that we don't have the money to pay the people. We've done workforce payment studies on Labor Committee, and the people in Wyoming are being paid equitably with regional or even higher. The problem is we haven't got the people to hire. So if there's no person here that you can hire, or nobody that wants to move to a wind-driven, tumbleweed-infested prairie, then
On some days.
that's right, a lovely wind-driven. Hey, look, I love it here. But so, we're already seeing. I think things that we have done in the legislature or in general, for example, the loan repayment program. If we were able to put money back in our loan repayment program, which was another one of my bills several years ago, we would that's a major attraction for physicians as far as recruiting. So I don't think, and you'll hear me, as I go through to, probably you'll think, well, she's for or against probably every other question. So, but I don't think that the Medicaid expansion would impact the workforce in a positive way.
Thank you. Naomi?
So just to add a little bit, another layer of complexity into this issue of workforce, it's really important to acknowledge that there has been really good academic work done on the impact of Medicaid expansion on workforce participation. And the reason this is really important is that there is something called the welfare cliff. For Medicaid eligibility, if you earn $1 more than the threshold eligibility level, you lose all benefits. So what happens? Individuals might have an incentive not to increase their number of work hours, not to take a raise, not to change jobs. That impacts their lifetime earnings and their prospects for upward mobility. So in talking about workforce development, you've also got to recognize that there's the other side of the coin, which is, will you keep people out of the workforce, and how will that impact the state's revenue and well-being for the community?
Thank you. Senator Whiteman, and then Chairman Swanson.
I'd like to add a more specific, nuanced answer based on my anecdotal evidence in Sheridan County, dealing with workforce. I know a lot of people, a lot of friends of mine who work out at the Spring Creek mine up in Montana, the coal mine. Their wives work at Sheridan Memorial Hospital as nurses or doctors or whatever. You lose the coal miners, they put up their house for sale and they're gone. And then you lose the nurses that go with it, and the school teachers and everything else. So there's even more complexity than what we even think about, and just locally, and I'm sure in John's community in Gillette, it's probably even more so, and all the coal mining communities. So it's very complicated when it comes to workforce.
Chairman Zwonitzer, and then we'll move on.
I think just to wrap that up, right, if we lose population, there's not as many patients, and you have more risk of losing. I mean, it's detrimental to the economy, especially in some of our smaller counties. And once you lose your local hospital, there's no recovering from that. So whether Medicaid expansion and more government dollars in the state now, make that difference or not, I can't tell you, but quality of life for low-income people living in Wyoming to have access to care, the studies say it's the same cost and we're improving lives. There's a workforce component to that too, about deciding to stay here when they lose their jobs. The one other quick response, we're number 2 as of last year in the number of Wyomingites who have to work more than one full-time job. Why are they doing that? Sometimes for money, sometimes for health insurance. If we had Medicaid expansion, yeah, it's probably true. Some of these people wouldn't be working 2 full-time jobs, and our labor force would go down, and it would have some detrimental effects to our economy. That's because people don't have to work 2 jobs to afford health care, and that's generally a good thing in many cases.
So I think you're talking about that general topic area called the working poor, perhaps.
Sure.
So let's talk about that. Had a dear friend of mine email me this. She said that she works hard. She pays $500 a month for her policy. That's only a catastrophic policy. She cannot afford to go to the doctor for anything. She feels she falls into the group where that she has no benefits at her job, working at the schools every day, not being a salaried employee. So her question is, would Medicaid expansion help her in Wyoming? How would it help the working poor if we were to expand the definition just a little bit? Is that an issue you've all thought about? Everyone shaking their head. Who wants to go first? Go ahead.
Okay, so yes, I mean, I think it does help the people who are piecing together part-time jobs to get full-time hours and to make ends meet. This is a group of folks who are, they're our neighbors and our friends that are doing the things that they need to do, and we have an opportunity to invest in them so that the stress and concern of taking care of their families is alleviated to the extent that we can do that. Ms. Lopez made an interesting point that I think ties into this as well, talking about ways of delivering care. And I think what the Wyoming has in front of us now is a decision to work on a Medicaid expansion that incorporates those things that she talked about, because the way that care delivered is extremely important for these people that need a little bit of extra support so that they can access care when they need it in the appropriate place at the appropriate time.
Yes, Representative Wilson.
This is another interesting question that has a lot of nuance, and obviously what we really need to do is be here until about August. I think that there are a lot of ways in which expansion would help the low-income poor. I myself, for example, some years ago, before I entered in the legislature, I taught 5 classes at a private school. I was considered to be part-time teaching 5 classes, which I don't think the public school system has it work that way, and I got paid about $14,000 a year. Now, my husband, I had insurance through my husband, but there were people working at that school, teachers, who that was their income, and we got no insurance. And one lady's husband needed some, I can't remember what his situation was, he had an aneurysm of something, and we pretty much passed the bucket to throw in money for his medication. So there are absolutely people who are working many hours a week who get no insurance through their jobs. Having gone on healthcare.gov, you can find some policies if you're in the 100 to 138% bracket, and if you work it out carefully, you can probably manage to have no monthly cost and a low deductible, but you have to be really sure to not get sick. So if you can bet on that, of course, that's part of the insurance methodology. So I do think that without Medicaid expansion, the low-income folks, and again, this is where, and I'm talking about the nuances, even in a state like Wyoming, there are real differences. If you live in Cheyenne or Casper and you have a very low income, you can go to, here in Cheyenne, to HealthWorks, say, for your primary care needs, or you've got bronchitis, something like that. You can probably get it taken care of there. If you are in a car wreck and you break your leg, you'll go to the hospital and you'll end up paying very little and you'll be on their charity care list. However, even in Cheyenne, if you have, let's say, diabetes or some sort of condition, a chronic condition with a medication costs, or where you need a specialist, you're really out of luck. Then if you live out in a rural area with no sliding scale in clinics, then I think you're even worse off than in Cheyenne. So and that's, again, as I say, why I'm here in the middle. I think that there is so much variety in people's situation, from the biggest city in the state, Cheyenne, to little places where you've got more or less access to actual providers, where you have more or less access to sliding care services. It's very difficult to come up with, well, this is the answer to that question and it solves everything.
Thank you. Senator Biden, then Naomi.
Yes and no to answer this question. Does it help the working poor? Yes, it would temporarily, but like Naomi pointed out, it is a trap. I'm concerned about that cliff of you lack the upward mobility at that point. You're faced with a very hard choice that you don't really want to put your fellow citizens in. Do I take this better job and lose my Medicaid, which is basically free health care, and take that leap and try to better myself and my situation? Or do I stay where I'm at because I know I'm going to have health coverage? I was working poor when I entered the workforce, but back then I could buy a high deductible catastrophic health plan for the same cost as my car insurance. Since Obamacare, those kind of plans have quadrupled in price. They are not affordable anymore to the low wage earners. You just cannot afford. It's stupid for a 20-year-old, 21-year-old to buy an expensive policy like that. It's pretty much your whole monthly budget. So what I would like to see is a reestablishment of an actual insurance market again. In Wyoming, we have one insurance provider. That's not a market, that's a monopoly. We need to get more competition, get insurance companies back in Wyoming, and have them fight it out in the free market, and prices will come down again. There'll be options again, and people want options. Wyomingites are fiercely independent. They do not want a handout. They don't want to go on welfare. They want to be able to purchase a product that fits them. And right now, with all the regulations and with Obamacare and everything else, that's just not an option. And by doubling down on Medicaid expansion, you're just increasing government more, and you're going down the road to single payer.
Naomi, before you comment, I'll go on the pro side, and then we'll come back and finish this question with you. Jan?
Thank you. So I want to sort of fall the middle between Representative Wilson and Senator Beitman. The HealthWorks that Representative Wilson mentioned is one of the community health centers that I represent. So there is people that are up to 100% of poverty level qualify for a sliding fee scale. This is not a free clinic. And the federal funding that they receive is only meant to cover a portion of the cost to provide care. So these organizations are funded federally, but also need to generate income. And so to my mind, both going to the hospital with a broken leg and expecting charity care and going to HealthWorks expecting a sliding fee scale is not sustainable. I've been around and a lobbyist for so long that I remember when legislature did pass an interstate insurance sales bill, and I remember when the insurance commissioner came back to the legislature to talk about the fact that he'd gone to the other states around us to see if they had insurance they wanted to sell us. And in every case, nobody wants to sell insurance in Wyoming. We don't have a big enough population. We're an aging population. We smoke too much, and we're not as healthy as we could be. So, you know, I don't disagree that it's a great idea, and believe it or not, I'm a pretty big capitalist myself, but I think that it has to be fair, and it's weighted against people who do not have jobs that pay $60,000 or $70,000 a year. The other thing I would add quickly is that the marketplace is there for those people who are moving from Medicaid to the marketplace. Remember that Wyoming has strong marketplace sales every year. About 25,000 people bought insurance on the marketplace this year. Over 90% of them got subsidies from the federal government. So they can better themselves, and that is the next step. So I do think that those are important things to remember as well. Thank you.
Thank you. One last comment, Naomi.
That people need health insurance for something catastrophic. And whenever you take a look at where the uninsured is trending, actually right now, you do obviously have a very big problem with the working poor. But now what you're seeing is upper middle class families forgoing insurance also because they have a card and no network if they live in a rural area, or the amount of money that they have to put forward before they get a first dollar of coverage is so high that they're willing to take that risk. But what I will say is that the problem with Medicaid expansion is that the rules that bind you to the Medicaid program make it very difficult to actually deliver the care to the people in the way that would best meet their needs and preferences and in the locations that would best suit them. And that's the real problem with expansion. If the federal government were just giving money to provide health care, you could do a lot of fantastic things to provide health care for the people that need it. But that's not what this program is. This program has a lot of rules and red tape that really siphon off a lot of those dollars that don't actually reach the patient and don't actually meet their needs in the way that we would want them to. And so I would strongly recommend looking at scope of practice laws, looking at certificate of need laws, taking a look at low-income pool federal dollars that could help boost your state pool and provide some subsidies there. Also take a look at the 1332 waiver, which is part of the Affordable Care Act, that would allow you to take federal subsidies, pass them through to non-compliant ACA-type care. For example, direct primary care, health savings accounts, insurance that may not be ACA compliant but would provide that financial security to those individuals who need it.
Naomi, thank you. Quick question. Representative Wilson and I had a discussion a month ago about the federal government's definition of rural is very different than Wyoming's definition of rural. But Franz, we got a question about the 19 or so thousand people that might benefit from Medicaid expansion directly. Do we know where in Wyoming they live? Is it just in a small part of the state? Is it all over Wyoming? Did your research get into that?
Greg, unfortunately, the state is not granular enough to get to that level. It really just breaks into four major public use micro-data areas around the state, so it doesn't get to the granular.
Okay.
I would assume it follows, roughly speaking, the population distribution of the state. So you have large clusters of Casper, Cheyenne,
Fewer in the more rural areas. Okay, thank you. Thank you. And for those of you watching at home, the best guess is it might find the normal population distribution within the state of Wyoming, more in the larger communities of Casper and Cheyenne and less throughout the state. Another question that was emailed to us that I think is something I haven't thought about, but I think is relevant. This particular viewer talks about Wyoming healthcare dollars going out of state. So the question is, would Medicaid expansion help those Medicaid help those healthcare dollars stay back in the state of Wyoming? And is that something worthy of consideration? Do we know? Chairman ZWONITZER?
I think the honest answer is we don't know. So as part of the Revenue Committee, we continue to hear, hey, all of Wyomingites and their taxes are paying this, and it's going to other states, not going to benefit those of us here in Wyoming. So I've tried now for 2 months talking to various federal entities, other people from nonprofit foundations to try to get that breakdown of how much is Wyoming paying as a state that's not going back to our people in the form of Medicaid expansion, and nobody can seem to give me that number in the federal government, in nonprofits. And so I think the answer is nobody realistically knows, but we do know that it comes out of our paychecks, and we haven't passed Medicaid expansion in Wyoming, so it's going somewhere. What that level is, no one's been able to quantify for me after 2 months of trying to find that answer.
Thank you. Okay. I think we can, does anyone have quantifiable information that's different than that? Jen?
So the positive side of bureaucracy is that Medicaid already defines the out-of-state care that Medicaid recipients can receive. So there are specific areas, specifically people can't necessarily receive care in Fort Collins, for example. So to some extent, I do think that the Medicaid program, I hope I said Medicaid before, the Medicaid program does have the ability to monitor that kind of care.
Thank you. All right, we'll move on. Do we know how Medicaid expansion would impact those who have private insurance? Would their rates drop, stay the same, go higher? Do we have information about that?
So there has been some studies done of states who have already expanded Medicaid that have shown some decrease in their individual in the exchanges for individual insurance. Our State Department of Health, Franz's report, and I realize that he would want me to say that this is not a guaranteed result, but their estimate of Medicaid expansion for Wyoming could potentially see a 5 to 15% decrease on the exchange.
Yes, doctor?
So I said that no one up here has malice, but there is malice in this particular market. And part of that malice is when Medicaid expansion started in 2013, CMS, as it oversaw the program, had a mandate to audit the program, a third of the states in it every year. So basically 33% of the participants. And they intentionally did not in 2014, 15, 16, and 17 because they didn't want to find people who shouldn't be in it. When it expanded that much, many people left their private insurance, which shrunk the risk pool. When we buy insurance, we're all throwing money in a bucket for shared risk. But for every 10 people that we put on Medicaid expansion, we lost 6 people out of the risk pool. So regardless of what the studies show, the number of people who are sharing the risk, which usually drives the cost of your insurance, shrank, which means that economically their premiums will eventually go up no matter what.
Thank you. Naomi.
I would be very careful here about talking about correlation and causation. A lot of what drives insurance costs in the private market has to do with the number of insurers that are available. And if you take a look at county by county, you don't have multiple insurers in those counties, and you certainly don't have them at all the tier levels. So the idea that expansion is going to somehow drive down premiums, I don't think is realistic. The other thing I'd like to talk about is some work that we did in Arizona, taking a look at what happened on hospital charges after Medicaid expansion occurred. Not only did hospital charges dramatically increase across the board for all payers, and that has, that deals with a lot of issues around consolidation and market power, but for the Medicaid non-emergent, non-admission, Medicaid, not only did Medicaid patients dramatically increase, but the charges that hospitals were charging tripled. And I think this is really important to think about what kind of power and money do you want to put in a select few hands. We also saw in Arizona, and like I said, we used American Hospital Association and HCUP data. in Arizona to look at this at a very granular level. We also saw the more urban hospitals benefiting dramatically more than the rural hospitals. So I would just be very cautious about predicting what's going to happen to insurance rates. It is a very complicated system. It has a lot to do with underwriting and the health of the pool, the number, of the risk pool. It also, and also the kind of, do you do blind risk also an assignment to these different pools. So I would just be very careful about that. But from what we saw from the hospital side, there was actually a very dramatic increase in what was being charged to patients across the board, and it did not benefit the rural hospitals. And that's another area I think we need to be very careful about. You've got to take a look, and it's possible to do this. Take a look at the number of beds in these rural hospitals and the percent capacity that you have, and then run an analysis of what the revenue is going to look like post-Medicaid expansion. I will guarantee you that Medicaid expansion is not going to save the rural hospitals. There is a very difficult transition that rural hospitals are going through across the country. If you take a look at California, for example, California was an early expander of Medicaid expansion. In 2018, 10% of all rural hospital closures across the nation occurred in California. Once again, correlation is not causation. And we have got to look at hospitals that are basically retooling for our current century, taking a look at telemedicine, taking a look at more direct primary care services, and behavioral health actually folds in nicely to this idea of providing more telehealth at these hospital locations in rural areas. And scope of practice ties into that as well. But we've really got to think about what happens 5 years down the road if you expand Medicaid. If you expand Medicaid, you're not actually serving those rural communities with better health care and access in most cases.
Naomi, I'd like to move on, but I'd really like to encourage everyone who's watching. I can't encourage you enough to take a look at the report authored by the Department of Health. It will allow you to understand what the data has said. I'm very guilty at times of using anecdotal stories to tell my story. And it's a very well done piece of work. The Department of Health spent a lot of time on it, and I would really encourage you all to take a look at it if you can. All right, so moving on. So we've heard a lot about how Medicaid expansion will impact certain populations. Talked about hospitals and rural hospitals and others. What about women's health? Do we know how Medicaid expansion in Wyoming would help mothers and especially younger women working in lower wage jobs that this particular contributor says compromise maybe up to 75% of minimum wage workers in Wyoming? How might Medicaid expansion help or harm their health care? Do we know?
I'm not a gynecologist, so what I'm about to say was a pound of salt, not just a grain. But I thought that we already covered that with CHIP for the most part, that particular service or need was being met. Having said that, as a corollary, and our concern that expansion may lead to misappropriation or abuse by people, realize that on a recent year, we had a 4% unemployment rate in the state, yet 38% of the babies born were born on Medicaid. And somewhere between 38% and 4%, someone got one over on us. And so that is another worry that we have about expansion is when we expand, we'll be even less capable of discerning those people who really need it from those who don't.
Oh, thank you. Jan?
Remember that moms who deliver babies on Medicaid immediately aren't on Medicaid anymore. So any postpartum care that they may need, they have to pay for themselves. So just from the standpoint of simply making that statement says that if they go through postpartum depression, if they need contraceptives to prevent another pregnancy soon, if they have some complication, they don't have access. So I think that just very basically Medicaid expansion would allow them to continue to get care, both of their primary care physician and their gynecologist.
Okay. Moving on, we've heard today that term waiver. And as it applies to Medicaid expansion, some states have approved Medicaid expansion with a waiver. In other words, it's all not one plain vanilla program that can work across the country. So the question is this: what are your thoughts about a waiver implementation, and what might that look like as perhaps an acceptable alternative in Wyoming for those that maybe oppose? Are there waiver options that would make it more palatable to you? Or even for those in favor, are there waiver options too that would make it more acceptable to you? Chairman ZWONITZER?
If I could start, right, the legislation coming forward doesn't automatically allow Medicaid expansion. What it really does is allow our executive branch to do the requisite studies and put a proposal plan to the federal government how best they see fit. And so the federal government may say, hey, not right, we're not going to allow this stipulation or putting it on this type of a waiver or doing some combination. But the proposal before us this year in the legislature is really targeted to finding, I guess I would say, the best option we can for Wyoming and putting our best shot forward if it were to pass. But there's no guarantee the federal government's going to go along with it. And so we have had, I'm sure Chairman Wilson can talk about, she brought a waiver 2 years ago. Through that process, there's pros and cons, and I'll let her cover those. But the legislation this year is designed to be as flexible as we could make it to allow the executive branch to get what we think is the best bargain for Wyoming.
Are you ready? Yep.
Well, I am. Since I've been in the legislature since 2013, and I would say the most common request, if I can call it that, from legislators as far as the waiver is to have a work requirement. Typically, the work requirements that the Wyoming legislature is in favor of require a person to have, let's just say, 20 hours a week of work, or be a student, or fall into a couple of other, maybe a training
Volunteer
type
service, I
program,
think.
volunteer service or something like that. The reality is, I don't think that waiver really matters, because already half the people who would be covered are working. And if people are going to school, that would be a good thing. So I personally don't really think a work or school type requirement would negatively impact many people. We could easily write it such that, if you lived more than 15 miles from a community, or, something like that. I think the main benefit of having a waiver like that is that it makes some people feel happier about voting for the expansion. So in that thing, I think the work requirement is probably a good thing as far as functionality. And I had another thought in there, but I'll have to pick it up later because I forgot what it was.
Just let me know. Naomi?
So the discussion around waivers is primarily around the Section 1115 waiver, which is the most common waiver that's used under Medicaid. And there are some really good things that you should be doing whether or not you expand Medicaid, things like eligibility redetermination, some co-pays. Work requirements is a great idea. Unfortunately, it is tied up in federal litigation right now. The real big issue around this is whether or not the purpose of Medicaid is coverage or whether the purpose is well-being. And so depending on where you sit in the political spectrum, you'll understand that that is a really important issue. Is this program to make people better off, or is it just to provide coverage? So the idea of putting in work requirements is a very risky one, in the sense that this is going to have to work its way through the federal courts for an ultimate decision. I'm not very optimistic that work requirements will be allowed under the Medicaid program, or if they are, they will have absolutely no teeth in them, making them meaningless. The other issue, though, that I've heard mentioned a few times is this idea that no state has rolled back their Medicaid expansion program. Well, that is something that will also end up in federal litigation. There are a lot of people who are JDs, I'm not one, but who have looked at this very closely. It is not clear if a state is legally allowed to roll back their Medicaid program. And so before you expand, you need to do an enormous amount of work on this question. And even states that have trigger legislation that says if the federal government were to reduce the reimbursement below 90%, we would roll back the Medicaid expansion. You need to check and see if that is actually going to really happen, because there are a lot of smart people who have done a lot of work on this who don't think that that is actually legal.
Thank you. Jan, then Dr. MANSELL.
I really hate to disagree with our guest here from the Goldwater Institute, but this certainly came up in our coalition, and we certainly wanted to do our homework on it. In contacting Families USA, which is a national think tank, we asked them if this was true. There had been rumors coming out of Montana that perhaps if you went in, you couldn't get out. And even though there's a lot of the parts and pieces of the ACA that have been changed over the years, this is one of the bedrock parts. No state is required to stay in if they go in for Medicaid expansion. Most of the legislation that we've seen over the years have that trigger in it, and I don't disagree with the trigger. I think that we do not want to unknowingly expand Medicaid. Certainly there's going to be costs, but we don't want to have the costs be because the federal match goes below 90%. But we can rumor this all that we want, but the bedrock is that CMS says that we can get out if we go in. The other thing I want to talk about is something that we heard earlier, and I think I misheard Ms. Lopez Bauman, which is that if there's a lot of cost overruns with the expansion, that somehow that would really endanger the regular Medicaid group, and truly that's not the case. Again, we can unexpand Medicaid, but we can't make any changes to that group that are traditional Medicaid. Medicaid's an entitlement. You can't change that. The match between the state and federal is there, and so our most vulnerable people are protected.
Before Naomi, Dr. Mansell.
So a couple of comments. One, actually states can change Medicaid, and what we see in healthcare as providers is when the state's budget got too stressed, what they've done is they've just cut back on reimbursement. So all the other qualifications of Medicaid are untouched, but what they actually pay out is different. I can give you an example. If you're a New Jersey anesthesiologist and you're doing open heart surgery, you're making $22 an hour. Guess what state's really short of anesthesiologists? The other point I would make is, of the waivers we're talking about, the waiver we should be talking about today is one where the state of Wyoming asked the federal government for a waiver from all the commercial restrictions on selling commercial healthcare insurance. The previous presidential administration issued over 900 of these, and there's no way they would ever defend another state asking for the 901st one, because it would put in jeopardy all the political favors that were given out to all the other friends of that particular party. And it costs the state nothing to ask permission for doing that. All we would need to keep is pre-existing conditions, and then let the insurance companies give us an innovative product. If I can build a Dell computer by deciding how much I can spend on a hard drive and a RAM and which keyboard and which monitor, I should also be able to buy an insurance policy that says I'm willing to risk this much for physical therapy and this much deductible for my pharmacy benefit. And if you let that happen, then we're more likely to have a dynamic and normal market.
Last word on this, Naomi, please.
I just wanted to clarify that the CMS has never issued a policy in writing that says that if you expand, that you can roll back that expansion. The law that governs this particular aspect is not in the ACA, it's actually in the Social Security Act. The other thing I'll point out is that there have been states that have gone to CMS, more, red states, that wanted to time limit Medicaid in the past couple of years. CMS has told them to strip that out. They did not think that legally you could throw someone off after a certain amount of time in the program. So once again, I would just urge you to look very deeply and ask CMS to put this in writing. If you want to expand, that you will be able to roll it back. My view is that they have never done so in the past, and it's probably because they don't think it's legal.
We're going to ask one more question and then give our panelists an opportunity for a quick closing statement. Final question is this. In states that have expanded Medicaid, what do we know about health outcomes? What do we know about health outcomes for the general population in those states that have expanded Medicaid?
So I'll mention a couple of different things. The first is there is an enormous body of academic literature that basically says that spending more on healthcare doesn't actually change your outcomes. Now, I know that I spend money on healthcare, and I do know that, I'm not going to stop. But the academic literature that's come out specifically on the ACA-related healthcare outcomes focuses on cancer. And, there's no question that if you have health insurance coverage, whether it's Medicaid or ACA, that your outcomes are better in a very serious disease of that nature. So we do know that that has been studied. Very little has been studied, though, on the lower end of care, on the more general practice type. But you know, I mean, obviously, we want people to have health insurance. We want people to have that financial security as well, knowing that if they get a horrible, life-threatening diagnosis, that they will be able to get treatment.
Thank you. Anyone else want to comment about health outcomes? Go ahead.
Sure. So there was a study released in August of 2019 that looked at that question. And what they found is that expansion between, I think it was 2014 and 2017, probably saved about 19,000 lives for the older age groups in that expansion group, and for particularly conditions that are amenable to treatment, right? So chronic conditions where working with a primary care provider, having access to medications allows you to manage your disease and actually saves lives. The Department of Health study on Medicaid expansion, I think, estimated, and I apologize, I think it was like 3 to 5 lives saved per year if we expand Medicaid.
All right, I'll ask for closing comments, and in your closing comments, I want you to include an answer to me. If I want to learn more and understand more and cut to the chase of what Medicaid expansion would mean to Wyoming, what should I do? Include that, would you, in your closing comments here? Chairman ZWONITZER, since we started at the other end, I'm sorry, but someone has to go first.
You should talk to your primary care physician, depending on where you live, and I'm sure every doctor in the state and nurse practitioner have their own thoughts on Medicaid expansion and whether it's best for their community and their patients in some cases. For my closing comments, I thought the best thing we set up here is we talked about options. And so I've been in the legislature for 16 years, and I'm at the point to say, hey, Wyoming, we're out of options in this area, right? We've had 10 years now you could buy insurance across state lines. Nobody wants to take us, right? Our health care is rural. As I talked about earlier, we have higher proportions of people who don't seek care, who don't have access to mental health services, the same as other states that have that economy of scale that we don't have. And so when I look at all the data and the studies, and I'll be the first to admit, you know, with NAOMI here, that there's not a huge drastic reduction of costs, but almost all the studies I've looked at say it stays the same or slightly better. And so if the costs are roughly equivalent and we can get a low-income population in our state access to better care, which I think will save us millions, if not tens of millions of dollars later on, I believe we should pass Medicaid expansion at this point.
Thank you. Naomi, you're next. And answer my question, okay?
So this has been a real privilege to be here with you all and discussing this very important issue. I would say that what I would want you to know is to take a look at New York and see where they cut funding with this budget shortfall. Are they going to cut services to the expansion population, or are they going to cut services to the most vulnerable? And keep in mind that there's no shortage of dollars coming into every single state to address the needs of healthcare. The question is, how can you blend and break that money to actually reach the patient, to meet the needs of those individuals? But that's what I would want you to know about expansion. I think that this is a really important opportunity here in Wyoming to don't think that you're going to have a silver bullet with Medicaid expansion. Do the hard work on the supply side. Do the hard work in the insurance markets. Do the hard work in really drilling down to figure out what kind of system is going to best meet the needs and preferences of those individuals who need care the most. And I think that you'll find it looks nothing like Medicaid expansion.
Thank you, Naomi. Josh?
Could you repeat your question?
Sure. If I want to really understand this issue in a better way, what should I do? How should I go about that?
Sure. So I think there's any number of people on either side of the issue in communities involved in healthcare who you could talk to. Certainly the group that put on this event today has a position and information that they're happy to share. On the other side of the coin is a group called Healthy Wyoming, who has a Facebook page and other information online where you can find it. And to be perfectly frank and not to oversimplify, there is no lack of information online about this issue on either side. A Google search of Medicaid expansion and pick a state will give you endless opportunities to read about it. One of the things, but just in closing, There's a few things I want to touch on. So somebody on the panel mentioned earlier, and I forget who it was, about is the goal of expansion coverage or well-being? And it's really both. They're not mutually exclusive. We have an opportunity, I think, to work with our policymakers, our Department of Health, Department of Insurance, our folks at CMS to create a plan that works for Wyoming. I know there's a lot of concern about cost and the share that Wyoming would have to put up in order to expand Medicaid. That's a fair question. And to our legislators on this panel, I do not envy your role in making these decisions. It's difficult. This isn't the only issue you face, and I appreciate your work. But looking at the experience of other states, I think what we can borrow from others. There's a number of states who, because of expansion, have saved money in their budgets because they were able to reallocate dollars. We already have in this state, I think, 6 or 7 Medicaid waiver programs. Now, I don't know what the scale of those are. I'll be honest. I don't know how many dollars we put into those. But there's an opportunity to move people in those existing waiver programs into the expansion group and receive a 90-10 match as opposed to a 50-50 match. We have other mental health services that come out of state general fund. Hospitalization for incarcerated people, that comes out of state general fund. These are folks that could be moved into a program that matches at a much greater level, and there are opportunities to save money. You look at Montana, Virginia, Arkansas, to name a few. Their budgets have been helped and supported, and they can reallocate dollars other places because they took this opportunity. So again, thank you all for the discussion, and thank you guys for being here.
Thank you, Josh. Chairman Wilson.
So Craig's question was, what do I tell him is how does he find the answer? And I think the answer is get some dice and throw them on the floor.
I'm a poor gambler. I'm sorry.
I do think it's kind of a gamble. And one of the things that makes me anxious about it is, so I was on the Labor Committee for 4 years, and then I was on Appropriations for 2 years. And now I'm back on Labor Committee. And I remember the issue that we had with our Title 25 expenses, so involuntary hospitalization for mentally ill folks, and when we have to hospitalize them at local hospitals because you can't move them out of the state hospital yet. When our budget started falling off in about 2015, the state's budget for Title 25 was, I believe, $4 million, I think a biennium. I'll just say, I'm not sure which was a year or biennium, but they were spending close to 20. And eventually, appropriations did let Department of Health have some extra money for that, and although they kind of tied it up in a big knot in the auditor's office. But for a number of years, the answer in that budget time was, fine, you have authority to spend that extra money, but you have to find it in your own agency. And so that was when we saw, not all for Title 25, but we cut the Department of Health $90 million. So the money that we saw in 2013, 2014, when we said, hey, we can expand Medicaid because we can shift, the costs for these mental health services, put them on Medicaid and take it out of here, really that money has been cut. And so I am very concerned if our revenue picture is the same, that we would expand Medicaid and then tell the department to find that money, $20 million a biennium roughly, inside your agency, and that we would end up trying to cut services to people with developmental disabilities or senior citizens. And as we've said, okay, you can't maybe necessarily cut the service, but if you cut the reimbursement rate to the provider, you in effect cut the service, because people will, if you cut their income by 30%, let's just say, they're not going to see as many patients. And that is my biggest concern about this. So I think, if we were to, and we heard someone, I don't remember say up here, but okay, maybe we deny the external cost adjustment for K-12 education. That's about the same amount of money as it costs to expand Medicaid. That will be an interesting argument. There are a few other things that we could cut, although most all the money we spend is either on education or healthcare or family services or corrections already. Or we could, raise your property tax. Certainly there's been an attempt at that in the Revenue Committee to change the valuation rate for residential and commercial property. Raise the sales tax. I mean, those are a couple of options. It's not realistic to say, well, we can fund it off of, doubling the beer tax. That's about $2 million. Sorry, that is not enough. So that is where I remain really tentatively trying to figure out the finances on this, just because from the state's general fund perspective, that's really what the job is. But I do want to say, and I hope that we can all commit to this, that whether we're for it or even if we're opposed to Medicaid, if it were to pass, by golly, I am going to do my darndest to make it work, because the citizens of the state deserve to have whatever we try to make to improve their health care work. So I think even if we're opposed to it, if we vote against it, I believe I will speak even for the providers, anybody, we will work our very hardest to make sure that people in this state have quality health care, and no matter where we come from, that's our job.
Thank you. Dr. MANSELL?
Again, I'd be more comfortable in an exam room today than here. But having said that, in medicine, we have what are called evidence-based treatments. And these are when we test a particular treatment, whether it's an antibiotic or a physical therapy modality or a surgery, and we look to see what the outcome is. Did it work or did it not work? Based on those of us who oppose Medicaid, looking at the 37 states, it doesn't look like it works. And I'll use an even more brief analogy. I own a biotech company, I do drug research, and if I have 37 test tubes in a row that the drug didn't work, I'm moving on. I'm not going to try that drug again. There are treatments and there are cures. A lot of the programs that we have in place today are treating a symptom of an inability to have access and the fact that healthcare has gotten so expensive. There's a cure, and it doesn't cost us anything. And it's very unpopular with the 27 hospital CEOs, who are very nice people anyway, and the 5 insurance company CEOs who sell insurance in our state. And it's to normalize the market. And the way you do that is really easy. If you buy gasoline and the price of gas per gallon is not on that pump, I think it's like $1,000 a day the gas station owner has to pay you. And yet, no one in a hospital has to post a public price list. When I sign a contract to be in network with an insurance company, and when I say this sentence and finish it, you're going to look at me like I'm the dumbest person you've ever seen. But when I sign that contract to be a provider with an insurance company, we are never given a price list. We have no idea what we're going to get paid. And to get that information, we can get it one at a time, one phone call at a time, usually on hold 30 minutes at a time. So here's a radical idea. Every provider in the state has to put online their price list. Every hospital in the state has to put online, not using a CPT code matrix, which takes a PhD in healthcare economics to read, but a plain English CBC, chest x-ray, ER visit format, a price list. And every insurance company has to publish on our contract, using not Medicaid multiples, Medicare multiples, but actually absolute dollar value, a price list. Where has this worked before? It cost me $600 to fly to Boston for college in 1979. That was a lot of dollars in 1979. I could do it now in Southwest for $99. Where did that come from? It came from price transparency, and it came from deregulating the aviation industry. This works. And you know what? Even as an experiment, if it doesn't work, it costs us nothing. Nothing. And the reason we've not done it yet is because the hospitals are caught in a horrible place where some of their contracts, they get paid X dollars for a procedure, and with another insurance company, it's 3X. And they don't want to admit what the price is they're charging publicly, because there'll be a transitional turbulence where the prices normalize. But if you publish it for all our poor people who have $5,000 and $10,000 deductibles, now they can make a rational market decision of, I'm going to go get an MRI here and not here because it's 3 times as expensive.
Thank you very much. Senator Beitman.
Man, the good doctor stole my thunder. I was going to talk about cost too. I mean, there's no downward pressure on costs, and that's, I think, missing from this whole debate on Medicaid expansion. There's so many things, like the doctor said, we could be doing to address the cost side. Americans are the best consumers in the world. We will drive across town to get save a penny on a gallon of gas, but we don't know how much our MRI costs from one place to the other. We could save $1,000 on an MRI by driving across town, but we just don't know what the prices are. That's a huge deal, and consumerism will drive down costs. We need to get that going. My biggest opposition to Medicaid expansion is obviously what it'll do to our state finances. I was elected to be a good steward of taxpayer dollars. 10% of a large number is still a large number, and we don't have that money. We are scrambling, scratching and clawing, looking under the mattress for quarters. We're not in any position to grow our state government at all. We need to be cutting our government. And like Representative Wilson was mentioning, she made a great point about what happened at Department of Health with those kind of cuts. It's real. We're going to have tangible decisions to make. This is a benefit. Who's going to pay for it? How are we going to pay for it? What are you going to cut to give this benefit? So you've got a cost-benefit analysis we have to do, and we have to have that serious conversations with our constituents. And it's not going to be easy. It's a touchy subject because everybody wants everybody to be covered. Going back to my opening statement, we're all here for the same reason. How we get there is drastically different, but we will get there one way or the other, and I hope it's to oppose Medicaid expansion and allow the free market to do its thing. Thank you.
Thank you. Jan, you had the first opening comments, you get the last.
I'm very privileged. Thank you so much. I again just want to thank the Wyoming Liberty Group and Wyoming PBS as well as Little America for this wonderful event. I also want to give a nod to legislators because as the legislators on this panel have indicated, they really are busy working at all programs, looking at everything. But I also want to say that they are willing to gamble money. They give tax credits to businesses to grow business in Wyoming. They, the legislature will spend money to gain money. And I think that that thing that's missing today is hearing from the actual people who are affected by this. So yesterday I went to my community health centers and I asked them to please send me any information about patients that they knew that were in the gap. And so one of the stories that came back I'd like to describe very quickly. This is by a young woman who helps people. My very first appointment for the enrollment period was a consumer who was dependent on oxygen to live. She was physically disabled and trying to apply for disability for the past few months. She did work, but not enough hours to meet the minimum income threshold to qualify for the premium tax credit. She ended up also being denied Medicaid because she was not deemed disabled by Social Security. But I would add that she also would have to wait 2 years. She was extremely upset because she was having trouble affording her oxygen, and neither one of the oxygen companies in town were willing to assist her financially. She started crying and said, "What am I supposed to do? Die?" This is worth a gamble. I think this is about people's lives, and I think that I will work very hard with legislators to provide common sense arguments that are based on fact that will really show that this is a gamble Wyoming should take. And I would also challenge the legislature to say, beyond opposing Medicaid expansion in all of these past years, beyond Healthy Frontiers, which happened many years ago, what are we doing to actually help those folks? I've heard some people talk about it today, that there's other options. I really hope, and I will work with people to find those options. And then finally, Craig, just to answer your question, I would argue that there are literature reviews out there, and we are seeing results from the states in the West that have expanded. Sometimes the arguments have been that the expansion data isn't equivalent to ours, but today I shared information from Montana and Idaho. I also would say that the state resources, the Department of Health puts out excellent reports. I would buff them up and make them look much shinier than they do, but that's because they're based on fact. And so I think that that's really the #1 resource we should be looking at.
Thank you. Thank you so much. To our panelists, a special thank you. Thank you so much for participating here this afternoon. Just very quickly before we go, I too want to thank Little America and especially the sound tech, probably the work that you've done for us. We appreciate it. To my colleagues, Stephen McKnight and Francis Sequoia, for their work in live streaming this important discussion. I appreciate your help today. It's my understanding the panelists will be available for you for interviews and discussion. Franz is still here. Jan is still here. If you have specific questions, now is a great time to ask. Thank you all so very much for joining us today. Dan, thank you so much. I enjoyed that. Enjoy it?
Oh, I'm not sure.